Hello all. I would like to, this is a continuum class of the last week's basic airway management. Now we get into the topic advanced airway management, in which we'll be slightly brushing up about the airway manuals which we have discussed in the last class. And we will see what the bag mask ventilation, any other adjuncts can be added to improve our bag mask ventilation. And there are other airways which would improve the ventilation, like supraglottic airways, and how to use them. What are the pros, cons of supraglottic airways will be discussed. There are some fundamentals of rapid sequence intubation also we will discuss. And we'll discuss about a failed airway, how to recognize and what are the steps and how to develop a mental model is what we'll be discussing in today's class. Coming to, as we discussed already, oxygenation matters always more than intubation. So what we think is intubation, airway management is mainly focused on putting some gadgets into the mouth is what always understanding is what most of the doctors feel or most of the physicians feel. But it is not putting some gadget across the vocal cords or putting the gadgets across the oral cavity. It is always oxygenation is what is paramount. So maintaining the oxygenation or supplementation of adequate oxygen across the respiratory system is what should be our paramount intention or our goal while managing a airway, any airway. It could be a difficult airway or trauma airway or a normal airway or during the ICU or in the emergency. Our paramount should be to maintain oxygenation. Because why oxygenation is most important? As we discussed, the brain injury happens within 4 to 6 minutes because it will not have any oxygen reserves. The brain tissue will not have any oxygen reserves. So within 4 to 6 minutes of hypoxia or a lower oxygen concentrated blood is being provided to the patient, to the brain starts to apoptosis. So the brain death starts to occur. Brain cell death starts to occur. So that's why the most airway deaths are due to hypoxia, not because of not able to ventilate. It is about hypoxia. The tube placement alone does not save a life. If we take some 5 to 10 minutes in putting a tube, during that time we are not bothered about the oxygenation. Just imagine, we'll have a successful tube placement, but there will be no oxygen during the time taken to put the tube, because our judgment will usually be failing while we are putting a tube, and while it is taking more time or not, we will not be alert of or aware of, which will lead to persistent or a prolonged hypoxia, which will further lead to brain injury or brain death, and we'll have a successful intubation, but will not be able to save the patient. So that's why always oxygenation is more important than intubation. So as we discussed in the previous class, I'm just brushing up about the manuals because the next airway adjuncts will also cover this part. That's why. So head tilt and chin lift. So this manuals are done to open up the airway. As we all discussed in the last class, the tongue fall is the most important factor which will cause airway collapse. So once the airway starts to collapse, even if you supplement air through AMBU or a bag mask ventilation, the air will not cross through the oral cavity and reach the lungs. So that causes airway collapse or a airway failure. So to avoid that, we try to do some maneuvers in a patient which would open up the airway and allow the air which we are trying to push inside the lungs through bag mask ventilation, like pressing the AMBU bag or a circuit or through a ventilator, etc. It will maintain the airway more patent. So these maneuvers open up the airway, like the tongue will be moved away from the hard palate, which will lead to opening up of the airway in an unconscious patient. And this head tilt, which will cause aligning of your oropharyngeal and laryngopharyngeal axis in one line, is usually contraindicated in cervical spine injury, because head tilt leads to movement at the cervical spine. If a trauma patient, when you're suspecting any C-spine injury or a cervical spine injury, usually head tilt is avoided. So the best thing to do in those patients is jaw thrust. Jaw thrust is to just displacement of the mandible forward, which will help you in the moving the tongue away from the oropharynx, which will open up the airway again. So this will not have any movement at the cervical spine. And if you have any patient, a trauma patient or a query cervical spine injury, in those patients, we avoid head tilt and chin lift and do a jaw thrust to open up the airway. So now even So now we have a patient who has a cervical spine injury, but we cannot do jaw thrust, head tilt and chin lift. Jaw thrust, we can do a jaw thrust, but it is not effective. Even with doing a jaw thrust, the saturation is not improving. We are not able to maintain the ventilation. Whatever ventilation we are giving through AMBU is not just passing through the oral cavity or the vocal cords and reaching the lungs. So what do we do in those patients? So we should, there is a gadget called oropharyngeal airway. So in the left side, we could see this image. The oropharyngeal airway is a hard plastic airway which has a patent tubing inside. So when you place this across the oral cavity, this will reach just posterior to the tongue. So just sits at the start of oropharynx. Even if there is a tongue fall, even if the tongue comes in this way, but because this is a hard plastic, this will not allow the tongue to fall and maintains a patent tubing, which leads to a patent airway formation, and your air gets across the vocal cords to the lungs. So this will prevent the tongue obstruction in a trauma patient where you cannot give head tilt or a chin lift. In jaw thrust is not effective, or an obese patient where even holding with two hands is also very difficult. Forming a seal with the mask is difficult. Putting up an oropharyngeal airway in the oral cavity would improve your bag mask ventilation effectively. So how do you size them? There are different sizes of it. This tip to this tip, you have to just place at the angle of the jaw, and it should go till the right in the ear. If that size is approximately, you just check it and usually insert it. From outside, you will check it and insert it while you are ventilating. So role of bag mask ventilation, it is always a primary rescue oxygenation. It is a bridge to intubation, and it is a life-saving skill. Till intubation, you can maintain oxygenation if you maintain this bag mask ventilation effectively. So there are two ways of doing it: 1% bag mask ventilation and 2% bag mask ventilation. When in bag mask ventilation, the most important role is played by the mask itself. So while you're holding the mask, there is a clamp called CE clamp. You could see there is C formed while holding this mask, and E is formed by the other three fingers. Okay, with this C, the thumb is usually at the tip of the mask, and the index finger is at the base of the mask, and this forms the seal. So this is, the mask is approximated onto the face of the patient, which will form a seal on the face of the patient, so that the air which we are giving is not leaking outside the mask or through this place where the mask is getting in contact with the face. So what does E do? This is what C does. C of the seal does. So what is E? E means, while these three fingers support the mandible and lift the jaw so that the airway gets opened up. So with the E clamp, we support the mandible, opening up the airway, and C clamp approximates the mask so that the adequate seal is established. So this leads to provision of an effective bag mask ventilation. In the same way, there are 2% BMV. So in that, 1% in an obese patient or a heavy jawed patient, or there is some bleeding or something happening, you need more support. So you can call in for one more help who can help you in pressing the bag. The self-inflating bag which is there in the AMBU will be pressed by other person, and this, the mask sealing will be done by the same person by using two hands, and this, there will be no CE. So the thenar eminence, if you could get the muzzle under the thumb, the thenar eminence is used to approximate the mask across the face, and all the other fingers are supported to lift the jaw and open up the airway. So this is 2% bag mask ventilation. What are the usual errors? As we said, the poor mask seal, even though while we are, if we give a good jaw thrust, but the mask seal is not adequate, this will lead to inadequate bag mask ventilation. Or in an obese patient or a very heavy jaw patient or a big tongue injury who has a tongue edema or some that type of patient, if we are putting good jaw thrust and putting good seal, even then there will be inadequate ventilation because of unpatent airway. So in those patients, again, you will have to put an airway adjunct, which would lead to opening up the airway, maintaining the patency of the airway, And continuing ventilation improves oxygenation of the patient, and you'll be able to save the life of the patient. And again, sometimes when there is excessive pressure, if you use while ventilating, along with the air going into the lungs, it will also enter the esophagus, which would lead to gastric insufflation. So when the stomach gets filled with air, this would lead to increased risk of aspiration, because the airway is not, it is just patent, but it is not secured at this particular moment of time. So that's why it is always important to avoid excessive pressure while squeezing the bag during bag mask ventilation. Till here, the bag mask ventilation aspect. So we'll go to the supraglottic airway. So one adjunct, as we have finished, is the oropharyngeal airway, which is used to place the keep the airway patent during bag mask ventilation. So next one is a supraglottic airway device. We are going slightly more deeper in this particular airway, where now we have put an airway only till the oropharynx, right, to maintain ventilation. This supraglottic airway device is just putting a mask not on the face but directly over the vocal cords, where the air has to directly get delivered. That will be supported by one tubing, and from to which you can connect a circuit or a ambu or anything you can connect. So it will just sit directly above the vocal cords. It does not require any laryngoscopy to visualize your vocal cords, but it will allow oxygenation and ventilation effectively than your bag mask ventilation, and it is used as a rescue or a bridge to the airway, definitive airway. So it is just a mask which is put over directly over the vocal cords instead of the face. So it will cut down the tongue part and the adequate seal issue which is there with your bag mask ventilation. It will directly sit on the vocal cords, and the air is delivered to the lungs through that. You could see this. So this is the laryngeal mask airway inside the oral cavity. So this is the mask which I'm telling now, the mask sitting over the vocal cords. The behind one is the esophagus. This is the trachea. So here will be the vocal cords. So the vocal cords just above the epiglottis, just below the epiglottis, this will deliver the ventilation. So this is a firm tubing. This is a firm tubing through which this connector will allow connection to the ambu directly or to any circuit which will allow ventilation. These are the parts. You could see these are two different types of supraglottic airway device. The left one is called Rigel. The right one is a normal LMA. So you could see the right side LMA is laryngeal mask airway. As I said, the mask which is sitting directly on the larynx, and this forms an airway. This is an inflatable cuff, and this is a silicone gel, right? So this silicone gel forms the seal over the vocal cord while you have inserted it. Here, once you insert it, you have to inflate the cuff so that the adequate seal is established. So this one all is hard one, which will not be collapsible tubing. And here this connector, which is 15 mm, gets connected to the ventilator tubing circuit as well, and also to the ambu bag. Same is here, the 15 mm connector connects to the ambu bag or a ventilator connector circuit. So when to use a supraglottic airway? There are different aspects where the supraglottic airway can be used. So it can be used as an immediate airway measure once you have tried intubation. So let's go with the sequence. The patient is unconscious and you have decided to secure his airway because he is not able to, there is increased risk of aspiration and he is not breathing well. Right now we give a jaw thrust and we'll ventilate with a ambu with 100% oxygen. So the oxygenation is maintained now. So next step, you try to secure a definitive airway, which is intubation. We'll get into that later, but just imagine we put a laryngoscope in the mouth, try to put the tube inside, but you are not able to visualize the vocal cords. There is a lot of edema, or there is difficulty in the position is not right, and you're not, for whatever reason, you're not able to visualize the vocal cords, and the intubation has been failed. So now, what I have said, the oxygenation is paramount. The moment you decide or realize that there is a failed intubation, you just get back to maintenance of oxygenation, because any attempt to establish intubation at the endotracheal tube inside or LMA during that time. It could be 30 seconds, 1 minute, 2 minutes, sometimes more than that. We are not providing any oxygen to the patient. So this is what you have to remember very much. So that's why you have to realize as soon as possible any difficulty which you are facing while establishing a definitive airway. So while you're establishing a definitive airway, if there is a failure in it, you're not able to put the tube in, or you're not able to visualize the vocal cords properly, you just step back, remove the tube, and get back to bag mask ventilation. So then now you realize the ventilation, so endotracheal tube insertion is difficult. Now you pick up a supraglottic airway device. This doesn't require any laryngoscopy. It is direct insertion. So you directly insert it in the oral cavity. The mask of the laryngeal mask airway or the supraglottic airway directly sits on the larynx. You connect your ambu or your ventilator circuit and it starts ventilation. So now the first indication, as we discussed, when there is a failed intubation, you use a supraglottic airway to bridge for the next step. Second thing, if there is inadequate bag mask ventilation, when there will be inadequate bag mask ventilation, as we have discussed prior, if there is an obese patient or you don't have a proper sized mask, or you're not able to, you don't have a second help, but the jaw is heavy, you need two hands to establish a proper seal well ventilation, or everything is there, but some whatever reason, the bag mask ventilation is becoming inadequate. So then what do? You pick up a supraglottic airway device, put it across the oral cavity, it will establish a secure airway and a pathway to provide ventilation to the patient. So any time where the intubation is failed, supraglottic airway comes to rescue. So it is a bridge to the definitive airway. And not to use supraglottic airway. This is also very much important. When there is, see, as we have discussed, where does the supraglottic airway go? Through the mouth. So if there is some severe trismus for anything like temporomandibular joint issues, or the mouth is not being able, you're not able to open up the mouth for any reason, or there is no enough space to insert the supraglottic airway device in the oral cavity, you would prefer to avoid supraglottic airway insertion. And if there is a higher aspiration risk, but it is not an absolute contraindication, it is a relative, just try to avoid if there is a full stomach patient. Preferably, it is not that your intubation has failed, but just because of the fear of risk of aspiration, you would completely avoid supraglottic airway insertion. No, it is not like that. You have to weigh between the risks and benefits between insertion of supraglottic airway or to avoiding supraglottic airway, and prefer avoiding it when there is a risk of aspiration. And there is complete airway obstruction. When there is a full airway obstruction like laryngeal, vocal cord palsy, or there is a full-fledged laryngospasm, because any problem below the vocal cords, the supraglottic airway will not really help, because when the problem is in the below the vocal cords or at the vocal cords, like the vocal cord palsy causing complete obstruction, or there is a big mass on the way, like a large thyroid mass causing complete tracheomalacia. In these cases, the supraglottic airway will not open up the airway. So that's why you avoid supraglottic airway in those patients. Selecting the correct size, it is always depending on the patient's weight. There are usually 3, 4, 5 sizes. Incorrect size again leads to a leak or obstruction. So usually while you're opening a supraglottic airway, on that, it will usually clearly mention what age, height of the weight of the patient. This is the right mask for. The position is usually sniffing position if possible, but it is not a compulsion that you have to always put it in a sniffing position. Neutral in trauma patient, as there is a risk of cervical spine injury. Jaw should be relaxed. So lubricate the posterior surface. The posterior surface is this surface. So lubricate the posterior surface because this is usually passing through your hard palate. So that's why it needs lubrication. So insert along the hard palate. So sit against the hard palate, insert it, then the soft palate comes, and again there will be a giveaway. Then the laryngeal mask pass through the oropharynx, and then there will be some resistance when it sits on the larynx. So You have to lubricate the posterior surface, insert along the hard palate, pressurize against the hard palate. Once the hard palate is crossed, you will get a giveaway. Then you insert further. There will be further resistance when the laryngeal mask airway reaches your vocal cords. So till then you will be inserting. So this doesn't need any expertise or video laryngoscopy. This can be put even in the ambulance. Paramedical staff are also trained for this laryngeal mask airway insertion. And inflate the cuff if applicable. If that is a laryngeal mask airway or a supraglottic airway device where cuff inflation is required, you inflate it, or else in this particular LMA, there is silicone gel, iGel, self-inflated, self-sealing technology is there that doesn't require further inflation. If you pick up the right sized supraglottic airway device, that will seal it automatically. How do you confirm? You confirm with chest rise while giving bag mask ventilation. The bag compliance also will tell you when there is refilling of the bag. Sonography, we'll come to that. So the ETCO2 graph also will tell you whether it is the position is right or wrong. Improved oxygen saturation. However, if the oxygenation is happening, the saturation starts to improve and maintain. If it is already good, the saturation maintains. The avoiding of the desaturation also will not happen if it is in the right position. What are the common problems? As we have said, if there could be air leak, because it all depends on the seal at the perilaryngeal space. Poor ventilation or gastric insufflation, because just 0.5 centimeters or less than 0.5 centimeter behind the larynx is the esophagus, right? If there is some air which is leaking into the esophagus, this leads to gastric insufflation and risk of aspiration. And malposition, anytime when you're putting in the LMA and you move the neck or head or the patient, mobilize the patient from one place to other, there is increased risk of malposition, which will again lead to weak or inadequate ventilation, which would lead to desaturation of the patient. So how do you troubleshoot all this? So first you reposition the head, you check that the head is not in a different position, or even then if it is not improving the saturation or the ventilation is not being delivered adequately, you reinsert the device. You try to remove the device and reinsert the device, readjust its position. You change the size, upsize or downsize the supraglottic airway device. Else, if all these three also fail, then you convert it to a endotracheal intubation, like a definitive airway or a surgical airway. Advantages and limitations of supraglottic airway. Advantages: fast insertion, as I said, minimal training is required, hands-free ventilation. What are the limitations? It does not fully protect from aspiration, as we discussed earlier. There is a risk of gastric insufflation and there is a risk of trickling of the gastric secretions into the perilaryngeal space, and there is a slight risk of aspiration, and it is not a completely definitive airway without any, you cannot completely maintain this patient for a longer period of time on supraglottic airway device for ventilation. You have to, this is just like a bridge, which is endotracheal intubation. So it is just a placement of tube across the vocal cords into the trachea is called endotracheal intubation. This is what is a definitive airway, because you can maintain ventilation on the through a ventilator or through anything, through the ambu without any risk of aspiration, because the cuff is inflated. This will prevent aspiration, and it is a definitive airway which you can maintain for a longer period of time, unlike supraglottic airway device, right? So this is what is endotracheal intubation. So the indications: altered mental status, protection of airway, anticipated clinical deterioration, failure to oxygenate or ventilate. So when you are planning for an intubation for any patient, you always have to have a checklist in the mind whether all these are there. Any of this is not there, you would prefer waiting for these to be arranged and then only start the intubation process. Because why? I'll tell you the importance of each aspect of it. Suction. So once you put your laryngoscope inside, there is an increased risk. There would be already secretions, there would be some blood, there would be anything in the oral cavity which would obscure your view of the vocal cords where you have to intubate, right? So that's why suction is very much important. Second thing is oxygen. So oxygen supply is anyway important. You are doing ambu already. And sometimes you also check the ventilator is connected to the, because once you intubate, you ventilate the patient through a ventilator. So whether the ventilator is having the proper oxygen supply or not, or the ventilator is connected to the oxygen supply or not, is what you have to always check. And airway devices, as we said, when the intubation is failed, you have to always check whether there is an oropharyngeal airway and supraglottic airway. To rescue your ventilation, you have to check. Next, pharmacy, which is drugs, like the induction drugs. It would be ketamine, which would make the patient deeper, sedate the patient. Second thing, or midazolam, the drugs. The third one is muscle paralysis. It would be succinylcholine or a rocuronium, which would be required to completely relax the muscles, induce muscle paralysis to allow you for intubation, is also one other aspect which you have to check before going ahead for intubation. Next is monitoring. As usual, the monitors which are already connected, you have to recheck the position of all those. And endotracheal tube, stimulate the video laryngoscope, whether also the laryngoscope, all those are working or not, which you have to recheck before you go ahead for intubating any patient. So patient positioning for endotracheal intubation. It is sniffing position, which is extension at the atlanto-occipital joint and flexion at the lower cervical joints, which is C6, C7, which would allow the alignment of laryngopharyngeal and oropharyngeal axis, which would help you in easy visualization of the vocal cords and early intubation. In obese patients, ramped up position is usually preferred, which, how do you attain the ramped up position, is the tragus should be above your suprasternal notch. Just imagine if you just put the sniffing position type of thing with one pillow for an obese patient, you will not be able to visualize the cords, or you will not be able to ventilate also, because this axis will not align the patient, the oropharynx to the laryngopharynx to the lungs. It will not align better. But in this, the alignment is better, the intubation is better, the ventilation is also better. The visualization usually improves with this. So in again, just in case if there is a neutral trauma patient where there is a risk of C-spine injury or there is suspicion of C-spine injury, you maintain neutral. So for intubation, so as I said, this see the left side images. When you don't use a sniffing position, the laryngeal axis, you could see the vocal cord is usually located just slightly anterior here. But if you put in a neutral position, you will not be able to see the vocal cords. In the same way, if you just put up the sniffing, the vocal cords would come slightly anterior. So for intubation, we need the visualization of the vocal cords. So how do you visualize the vocal cords? Usually when you open the mouth, you will only be able to see the tongue, maximum of the hard palate, right? So swept away from your cavity, like it is moved to one side, you will be able to see behind the tongue. So what is there behind the tongue? Behind the tongue in the oropharynx region, there will be epiglottis, which will covering your vocal cord. There's a curtain-like structure which we read in our first year anatomy, which will be covering and protecting the vocal cords. So you need an instrument which would sweep out your tongue to one side and give you the vision of the vocal cords. So that's why you have to hold the larynx with the left hand, insert it from right corner mouth. The laryngoscope has that provision to include the tongue in that blade. You just move it across to one side, right, and lift. Once you lift, you will be able to see the epiglottis. Once you lift, you will be able to see the epiglottis. Once you lift the epiglottis, you will see the vocal cords. This is how it is. See the image A, where the tip of the laryngoscope blade is going till the posterior part of the tongue. Above it is the epiglottis. Just below that epiglottis, you will be able to see the vocal cords, and this ET tube is being inserted or advanced through that. If you see this image, so the star which is there is the epiglottis, which is lifted over the laryngoscope blade. you see the vocal cords here. These are the false vocal cords which are shining. Inside there is white slit-like structure. These are the true vocal cords. Across that vocal cords, you will have to insert your tube so that the ventilation is established. You see, this is the reverse image of it. So the epiglottis is here, vocal cords, and the trachea, which we could see the first tracheal ring visible here. So some more images for the better understanding. So this is the tip of the laryngoscope, which is placed just above the vocal cords in the valleculae. Once inserted, you could see the C image where the epiglottis gets lifted over the laryngoscope blade, and you will be able to visualize the vocal cords here. And this is the glottic opening through which you have to insert the tube. So just to visualize the vocal cords, even the epiglottis included laryngoscope blade, and you will be able to see the vocal cords here like this, white and shining. This is how the vocal cords are. So advance through the cord. Once the cuff is passed across the tube, across the vocal cords, you usually stop, remove the still, inflate, connect the circuit and start ventilation. So how do you confirm whether your intubation, whether the tube is inserted in the trachea or in the esophagus? Because unrecognized esophageal intubation is even fatal, because now you stop normal ventilation and the tube is in the esophagus, and you continue ventilation and the air is not going into the lungs, the oxygenation will not be improved, there will be further desaturation. So that's why you have to always immediately identify whether the wrong placement of tube has happened or not. So visualizing the tube is just visualizing the tube that you are sure that under vision you have put the tube is insufficient. So confirmation should be done immediate. So one important way to confirm it is the waveform capnography or the end tidal carbon dioxide measurement. So there is a apparatus to it, apparatus to the circuit, which you can connect this CO2 monitor. It will the carbon dioxide in the exhaled air. If it is in the esophagus, this will not be, because in esophagus we know continuous supply of carbon, and that air will not be coming into the there will be no air. Even though there is some air, there will be no continuous air out, right? So that's why there will be no continuous CO2. There might be initial spike, but further it will be coming down. So that is the sign of esophagus. If it is in the trachea, there will be continuous release of carbon dioxide from the lungs into the exhaled air, right? So that's why there will be continuous EtCO2 reading, which will be coming up in endotracheal intubation. If it is an esophageal intubation, the carbon dioxide levels usually come down gradually and it will become zero sometimes. That means that is a confirmation that the endotracheal tube which we try to place here has accidentally inserted in esophagus. So a continuous monitoring detects displacement. Minimum 5 waveforms are required to endotracheal intubation. It is not one, because if you have to see only 1 or 2, the air which got insufflated also comes back into the air which got insufflated into the stomach while we are doing bag mask ventilation will come out through the tube while we have placed in the esophagus. So 1 or 2 normal waveforms also might come even if the tube is in the esophagus. So that's why minimum of 5 to 6 are required. Waveforms are required. The EtCO2 waveforms are required for ventilation, and only that confirms your endotracheal tube placement. So what are the different, see how do you label these, or how do you read these? So this is a square shaped waveform which is formed on the monitor. So what does this, so here the y-axis has EtCO2 and x-axis has time. So EtCO2 is the end tidal carbon dioxide, the carbon dioxide concentration in the exhaled air which is coming through the tube. So here, if you see the EtCO2, the carbon dioxide concentration is slowly increasing, then it is getting plateaued and decreasing. So just let me know when does the carbon dioxide concentration decreases in the inspired air. So during inspiration, the carbon dioxide will not be there, no, while we are inhaling. It will be mainly oxygen. So that's why the amount of carbon dioxide decreases. So then during exhalation, the carbon dioxide which is collected from the deoxygenated blood is picked up in the exhaled air. So slowly there is gradual increase in the CO2. Then it reduces and then again it decreases. So this is what confirms the tidal volume or the ventilation. So that's why 6 of this waveforms minimum are required to confirm endotracheal intubation. What are the other methods to confirm endotracheal intubation? Bilateral chest rise, auscultating bilaterally, and again you have to auscultate in axillary regions. On the anterior region, you might get a transmitted sound, or you would not hear it clearly. The patient is having very much tachycardia or the patient is cachexic, you will not be able to hear it properly. So that's why infraaxial region is all right location to auscultate. No epigastric sounds. In the epigastric region, you auscultate, but there is no gurgling or sounds over there. That also confirms it is there. And the saturation, which is already there, is improving or maintaining, is also sign of confirmation. This is another list. So direct visualization, movement, auscultation of breath sounds, absence of epigastric sounds, presence of an exhaled end tidal volume graph, result bag compliance, endotracheal cuff maneuvers. The once the tube is inflated, the cuff is inflated, right? So you would check the pressure of the cuff. So each esophagus is a stable tube, right? So if you inflate more air in it will allow the inflation. The pressure of the cuff will not increase, but the trachea is having cartilaginous ring, right? So that's why the pressure starts to increase if you inflate more air in the endotracheal. So absence of air escape, condensation with exhalation, absence of gastric contents within the tube. These are all many other ways to confirm the endotracheal tube placement. And how it is measured means if you want to just have a monitor something, persistent pulse oximeter readings or improving pulse oximeter readings, end tidal carbon dioxide measurements, esophageal detector device also is easily available but not used regularly. So you always make sure X-ray, how many ever monitors are being checked, you should always check the X-ray after you intubate. So chest X-ray should be the tip of the endotracheal tube on the chest X-ray should be 3 to 5 centimeters above the carina, because any mode just tell you whether the tube is inside the trachea or not. It will not tell you how deep your endotracheal tube has gone in the trachea. It would directly go endobronchial systems. It would directly go into the right main bronchus if you just blindly insert it completely. Or sometimes if there is a short neck and you miscalculated the depth, again it will go inside. Or sometimes it is just at the vocal cords and it is slightly outside. That also causes problem. So it's always important to have radiological confirmation of the endotracheal tube. As we said, CO2, increased airway pressure, sudden desaturation, or unilateral breath sounds would high airway pressure. Why high airway pressure? Because the tube has gone too deep. So once the tube has gone deep, the tidal volume would take for 2 lungs, we are providing 1 lung. That's why the airway pressure is to increase. So that is one sign that tube slightly is not at the carina. Sudden desaturation. If the tube is slightly out, the cuff is not inflated well, there is air leak. So that's why the ventilation is inadequate. This would lead to saturation. Or a unilateral breath sounds, as I said, if the tube is too in again, one side there will be no air entry. That also confirms that there is malposition. Proper ventilation would not ETCO. So if there is no ETCO2, the tube is not in the right place, it would be too outside. Unilateral is too inside. High airway pressures, again it is too inside. And desaturation, it would be inside or outside as well. Any which ways there would be desaturation. Intubation complications, there would be, they said, hypotension, hypoxia, aspiration. So now why aspiration occurs? So during bag mask ventilation, we would have ventilated it for quite enough time to maintain oxygenation. The air not only going into the trachea would have gotten insufflated into the stomach. Once you try to laryngoscopy the and you usually give this relaxant for intubation, also relax your esophageal sphincters that lead the gastric content to get regurgitated into the oral cavity. There is a risk of aspiration and as I said, if it more time for intubation or any of the previous positions happen, would lead to hypotension. It is a multiple reasons for due to the hypotension occurs after intubation. It could be due to the drugs which we have given for intubation, or could be the prior condition of the patient where the sympathetic system is maintaining the vitals. After we anesthetize or we sedate the patient, that sympathetic drive is lost. That would lead to hypotension. There would be many reasons for hypotension after intubation. I said if it is too in, that also would. Failed intubation response. As I said, anytime if you recognize that the intubation is not happening, so till we have discussed about successful intubation. Now the intubation, you are able to visualize the cords, number one. Number two, you are able to visualize the vocal cords, but you are not able to pass the ETT. You have passed, but it is causing trauma and it's more bleeding, and you are taking it out, but not able to visualize. So there are any number of ways, reasons intubation failed. But the most wise thing to do is identify early, sooner, so that you will be able to risk the oxygenation. So oxygenation with bag mask ventilation, stop the attempts, maintain the oxygenation with bag mask ventilation, insert the supraglottic airway device. Okay, so now you have declared that the patient, you are not able to intubate because of trauma which has happened while inserting the endotracheal tube or trying to in the endotracheal tube. There is a trauma or some laryngeal edema or a laryngospasm which has happened. Once you start try to oxygenate, you're not oxygenated well. Now with supraglottic airway device also or mask ventilation also, after you tried intubation, now you're able to ventilate. Imagine there's a patient who was unconscious. You have decided to intubate the patient. You have initiated with bag mask ventilation. You have maintained the ventilation well for 3 to 4 minutes. Everything, all the equipment which is required for intubation has been arranged. Now you have when the rocuronium, and then the patient is relaxed. Now we have put the laryngoscope inside. You've got a nice vision of the vocal cords. You have tried to insert the tube, but now you could not insert because the axis is wrong or something. Then again you have tried trauma to the vocal cords or the vocal cords. It started to bleed. The blood is filling up there. You try to sort, but it is bleeding further. Now you realize this situation is filled. You start to ventilate the patient back. So now put the bag mask ventilation back. You give a good jaw thrust and seal it and try to ventilate. Now you are not able to ventilate because that trauma has caused laryngeal edema, and now the air is not passing through the larynx. And now you have picked up a supraglottic airway device. You have inserted the supraglottic airway device, and even with that, able to ventilate, then oxygenation. Because as I said, supraglottic airway devices will not help in any problems beyond and beyond the cords. Now the vocal cord edema or laryngospasm has occurred, causing complete airway obstruction, and you're not able to ventilate this patient, not able to intubate this patient. So this is the situation where you call can't oxygenation. This is also called complete ventilation failure. So this is what happened: failed intubation, failed bag mask ventilation, failed supraglottic airway device. With any of these, you are not able to improve the oxygenation of the patient. So now you have to proceed to cricothyrotomy. What is cricothyrotomy? Break this term. Cricothyroid membrane otomy is opening it up, right? So what is a cricothyroid membrane? Cricoid and thyroid. So this is the cricoid cartilage. You could see here, and this is the thyroid cartilage. So there is a membrane connecting the thyroid cartilage and the cricoid cartilage in the larynx. That is called cricothyroid ligament. So this ligament can be identified by identifying the thyroid cartilage, which is called the Adam's apple. Below that you go, And before starting off your first tracheal ring, the tracheal cartilage, you would feel there is a small membrane. You can identify it while you're touching across your throat. So once you identify that, stretch the skin, open it up with a scalpel and put the tube inside. You will be able to establish ventilation again. Got it? See, this is a cricothyroid membrane. You put a scalpel inside, slit it, slit open that cricothyroid cartilage. See, you first palpate and identify, slit open the cricothyroid membrane, put a bougie, put a endotracheal tube across that and start ventilation. So initial incision, open it up, endotracheal tube, or put a bougie and put an endotracheal tube across, railroad the endotracheal tube. Any which ways you can do depending on the size of the opening which is available over there. And now you establish ventilation, because now with this you go below the vocal cords, because there is laryngospasm. Below the vocal cords you have established the airway, you will be able to ventilate this patient. So that's why difficult airway, the mental model has to be established well. This is the main purpose of this class. Oxygenate, oxygenate, oxygenate. Oxygenation is the paramount. Attempt intubation. It is failed. Restart bag mask ventilation. If it is failed, a supraglottic airway device. If that is also failed, try to establish cricothyrotomy, surgical airway. So the take home message is oxygenation over intubation always. Use the algorithms, clear algorithms, and why those has been established. So early help always saves life. So we'll discuss a couple of cases. Almost we have just 3 to 4 minutes. So any doubts here till now? We'll go to the cases. We'll go to the case discussion. He's a 65-year-old male, pneumonia, saturation is 82%, BP is 80/50, agitated and tachypneic. And we have decided to intubate the patient because of severe hypoxia, shock, and risk of aspiration. So what would be the airway plan? So as we said, we have to pre-oxygenate, rapid sequence induction, prepare supraglottic airway backup. Choice, ketamine induction. Why ketamine? Because it helps in maintaining the hemodynamics well and allows the patient to get sedated. This also will be discussed in the later sessions of airway management. The drugs, rocuronium paralysis. Go ahead for intubation. So, obese patient with difficult mask. He's 120 kg, saturation is 86%, poor mask skill. As we said, what would be the best one to use here? Difficult mask ventilation is there. How do you optimize it? You use a ramped up position, number one. Number two, 2% bag mask ventilation. Even if it is difficult, you try to optimize it by insertion of a oropharyngeal airway. The next steps. Further, bag and mask ventilation is poor. Even with oropharyngeal airway insertion, as we discussed, you try to insert a supraglottic airway, maintain oxygenation, optimize the oxygenation, and then you try intubation. The same again, road traffic accident patient, when there is a suspicion of C-spine injury, the GCS is 7. There are too much of bloody secretions in the mouth. As we said, the risk of C-spine injury is there and risk of aspiration is there. That's why you decide to intubate, but you have to give jaw thrust, avoid chin lift and head tilt, inline stabilization, avoiding movement at the cervical spine, rapid sequence induction, protect the spine, protect the airway. Now the tube is placed, the saturation is dropping to 85% from 92. What would be the differentials? It would be esophageal intubation, it would be endobronchial intubation, it would be displacement, like the cuff is slightly out. For each thing, check EtCO2, auscultate, withdraw the tube, reconfirm the tube. So this is how you do it.